in the lives.
Okay, this is health and welfare. We're back. It's still March 12th. Is it?
It is, you got it.
We're moving along quickly. And we have some testimony on healthcare payment types and delivery system. Part of our committee bill is to understand payment and delivery system generally, but payment reform is also critical for us. So we've invited Jessica Moschella to be with us, and she'll introduce herself in a minute from the University of Vermont Health Network, and we're very pleased that you're here. So let's introduce ourselves first, and then we'll ask you to introduce yourself.
Senator Larry Hart, Punchkin.
Sam Douglas, my home East County.
Jenny Lyons, Chittenden Southeast.
Thank you, Chittenden Central. And Cummings, Washington District, right here. And I just got a text that said that my son's novel has been published.
Very exciting. What's his name?
So I'm excited. Wow. Soroka. It's about his experience in Tomsk, Siberia.
That's right.
That's
This happens. Linda, is there a way to make that fill the screen? You do that?
I think we're having an issue with the sharing because it's
Okay.
showing up on my laptop as like a presentation mode, but for some reason it's not showing up.
Try and do it again, see what happens. I don't know.
Or if there's maybe someone that should share it.
But so Jessica, please introduce yourself to us so we know who you are and your expertise, a little bit about your background, and then we'd love to hear your testimony.
Thank you. Madam Chair, members of the committee, my name is Jessica Moschella, and I am the Senior Vice President, High Value Care for the University of Vermont Health Network. What that means is I have the responsibility for population health management, value-based payment model, and the transition of our healthcare system to a value-based organization from a volume-based organization. My background initially is in public health. I was a Peace Corps volunteer in South America, and I did work in the AIDS epidemic, mostly in South Africa, but also some in Zambia and Zimbabwe. And then I spent a good portion of my career in community-based care in the greater Boston area, including HIV care, school-based health centers, and a number of school-based health centers, transition, a lot of really deep public health work. So what you all think of when you think of traditional public health. I transitioned to the Commonwealth of Massachusetts, where I worked for the Secretary of Health and Human Services, overseeing an agency called the Healthcare Quality and Cost Council. It was under the first legislation in Massachusetts, set at looking at cost containment goals, quality goals, and transparency was the role. My position there was legislated away with the second wave of legislation, and that introduced the Health Policy Commission in the Commonwealth of Massachusetts, which is the regulatory entity in the Commonwealth. At that point, I went and transitioned to an integrated healthcare organization where I was the first director in population health management before population health management had a name, and spent about a decade in and around that organization, mostly in the community side of that organization. So working with independent primary care and specialty care practices across the region, really integrating it deep into population health. So that is a little bit more about who I am and what I do. Why did I come?
I'm trying to figure out how you did all of that in such a short.
I know.
You're not. Well, anyway, go ahead.
It's over 20 years of work.
Amazing.
At this point. So why did I come to Vermont and move my family to Vermont and come here? Aside from Vermont being a wonderful place to live and a great place to educate your children, all of those things are important. My career in public health, community health, population health management, and state government led me here because I believe in what you all are doing. The foundations would really truly change the way healthcare is delivered and paid for, I believe is possible in Vermont. I believe we can make together, and I think it is a lasting impact on the region, and also potentially more broadly. I think that the foundations and the principles are here. One could argue that the most urgent issue facing rural America is the health and well-being of its residents. The Agency for Health Research and Quality reports that life expectancy in rural areas are significantly lower than those who live in other parts of the United States. That gap, you all know, is widening. Major factors are the chronic conditions that you all have heard about: heart disease, lung cancer, stroke, diabetes, substance use disorder, suicide. I chose to move for the position that I have today, just over 2 years ago, to work within a healthcare delivery system to make the necessary changes to impact your families, our neighbors, our friends. I believe in the foundation that you all have built here in Vermont and our ability to make real change. To begin to talk about how we're going to do this together, that's why I have my slide here to really think about the models of care. I think it's important that we have shared vocabulary so that when I talk about terms, you know what it is that I'm referring to. These terms: population health, global budgets, reference-based pricing, total cost of care, affordability, prices, they can easily be intermingled. And so I want to define what it is that I'm talking about.
And just to the committee knows that you'll be sharing your written test.
I will.
So that's good.
Yes. So the first model of care is the one that you all hear about probably the most, and it's the fundamental way that the healthcare system has built, not here in Vermont, everywhere. It's built around the idea of fee for service. It's the way a lot of businesses work, right? You pay for the goods that you're purchasing. You pay for the fee for the service. That's the predominant model still in the United States. Paid for performance. Sometimes you hear this as a quality bonus. Sometimes you'll hear this referred to as P for P. This is still fee for service billing mechanisms. So you're still billing fee for service. There are quality incentives that could be in a Medicare contract. It could be in a Medicaid contract. They also exist in commercial contracts. That's where you basically are saying, here's a set of quality measures and you get a payment for achieving these measures.
Do you want?
I'm fine with that question.
I was, in terms of the fee for service, do other developed countries use that model?
That's a great question. Healthcare in other countries is financed so differently. I would say that there's components of fee for service in other countries because they have to anchor it to something. But their overall, the way they finance their healthcare at a national level is so different than the way that we do it. And it's kind of outsourced. And in other countries, they do still sometimes have private insurers, even though there is a public system. And so billing would occur in that case.
Thank you.
Bundled payments. Medicare has done a lot of exploration in here. The example I use in the Medicare space is think orthopedics. So a hip replacement, for example, a bundled payment would be a payment that would be received for the procedure, but also the work pre-op, and then if there's a rehab stay that's required. And so the entire episode is a bundled payment. In the commercial space, I say think about OB care. So pregnancy care and childbirth is often paid in a bundle. Total cost of care or shared savings contracts. This is the way a contract is negotiated where you have a target, a spend target for a defined population. And the provider organization is responsible for delivering all the care necessary for that population within that target. If they don't, they're paying a check to the payer. If they do, that's where there's shared savings, and both the payer and the provider share in those savings. And I'll talk a little bit more about that and how that works as I go. And capitation. So I really want to make sure I'm clear. This is capitation with quality. Capitation without quality is what we all experienced in the 90s. That's partially why things went awry there, without giving you a whole talk on why that went awry.
Care rationing.
Care rationing.
Yeah.
Care without
We
data.
want to avoid that.
Correct. Care without data, care without quality. So when I talk capitation here, it is when you have a fixed payment, a fixed budget, and you have to deliver the care within that. Quality is still very much important. The arrow along the bottom is a note here to say that in a fee-for-service system, your payers are bearing all your risk. And as you get to a capitated model, your providers are bearing the risk.
And it seems like neither extreme is good necessarily.
I think there's reasons that you potentially could use all of the components here. So people often ask me, is the goal to get everything to capitation? My goal is to get as much as possible to the right, to get more into the total cost of care space and more into the capitated space. There are still things that you may want to have in a fee for service. So other countries is probably a good example. There may be things that you would want to keep in that mechanism, but not the majority of your system.
So capitation is not necessarily tied to, rationing and poor quality healthcare. Because that was what we saw in the 90s, as you said.
Yeah, and I guess some people may say that's what you might see potentially in some other countries as well. The challenge is how large is your budget, right? So if you have a limited amount of dollars, if you have a fixed amount of money and you have an entire population that you're trying to deliver all the care for, the question could become what care is necessary to whom when. Another way to say that is what's the right care in the right place at the right time. But there is a flip side of that. So I want to just define a little bit when I mean total cost of care. Put your payer hat on for a second. When we think total cost of care, it's all of the care associated with the coverage of an individual over the course of a prescribed period of time, usually a year. So when you talk about that, we're usually talking about something called a PMPM or a per member per month. And I'm sure you've heard these terms because you are all now well steeped in this language. So typically that's what I'm talking about when I think about total cost of care. There is a total cost of care for an individual, that the individual, myself, when I think about my own consumption of healthcare in my family, I think about my copay, my deductible, like that's my cost. But when I refer to total cost of care, I'm thinking about the entire episode of care for a population over a year, much more like a payer would think about it. So as you all know, we've been stuck in this fee for service model for a long time. We know the problems with it. The highlight I point to is the report that came out from the Institute of Medicine in 1999 to Errors Human, pointing out that at that point in time, errors caused in the medical system was responsible for somewhere between 44,000 and 98,000 deaths in the United States every year and about 1 million injuries. Following that, there has been a lot of work nationally to think about quality, to embed quality in the work that we're doing in hospitals and ambulatory care. Vermont did an extraordinary amount of work thinking about what's the foundation that needs to be built to get to these new models of care. So the two things I'll point to in this particular case is the Blueprint for Health and the concept of a statewide ACO for all payers,
Which is disappearing.
fundamentally, the concept is important, and the mechanism, the building of the blueprint, in many ways is a landmark. And so I think that there's a really important thing to say. Vermont has been thinking about this for a long time in across for your entire population, which is really laudable. I'd like us to see the things that we need to do to work together to get to the right of the slide. There's a responsibility for a large healthcare delivery system in that, there's responsibility for the legislator in that, and there's responsibility for the regulator and quite frankly, larger players. It's a yes and situation when I think about this. I want to highlight a little bit another body of work. So Atul Gawande often writes in the New Yorker. He's a physician, and some of you may have read some of his work. In 2011, he wrote a piece called From Cowboys and Pit Crews. And what he talks about, and I'll quote him here, the core structure of medicine, how healthcare is organized and practiced, emerged in an era when doctors could hold all the key information patients needed in their heads, manage everything required themselves. One only needed an ethic of hard work, a prescription pad, a secretary, and a hospital willing to serve as one's workshop, loaning beds and nurses for patients' convalescence, and maybe an operating room with a few basic tools. We were craftsmen. He goes on to note that in 1970, the average hospitalized patient required 2.5 FTEs, full-time equivalents, for their care. By the end of the 90s, it was 15. Why? Why is that the case? Well, think about the advent of pharmacology. Think about the transition from paper to electronic records. And quite frankly, when we were in a paper system, none of us really know what kind of quality care was being delivered. Now we are measuring all of that work that we're doing. I don't know how many FTEs are required today, but I would be surprised if it wasn't more than 15. A system that is built on specialized knowledge with specialized components of care, really inclusive of primary care. Our primary care are specialists in the type of care that they deliver, is going to have enormous difficulty transitioning. And then you layer on the cost of care on top of all of that. He goes on to say, we train and hire and pay doctors to be cowboys, but it's the pit crews people need.
The farrier, we need the farrier.
You need the farrier.
Shoes on the horse.
The pit crews, how do we ensure the pit crews? So those pit crews are population health. Those are the care teams that use the data, the claims data that comes from payers, the clinical data that's in the EMRs to figure out who needs to be seen when, to reach out to the patients that we haven't seen in some time and we know have chronic conditions and that likely have unmet needs. Those are the pit crews. Those are the fundamental elements of population health. So turning back to the shared vision that I'm referencing, that we all need to work together to understand and fix. You've all heard of the foot in two canoes analogy, one foot being in fee-for-service, the other foot being in a value-based care. We have to get our feet out of these canoes. And as long as we have too much balance in a fee-for-service system or too much weight in that predominant methodology, we're never going to be able to lift our foot out. And so the systems are still based in this billing mechanism that is really anchoring us down. So let's talk a little bit about examples of these models. So I talked about them in concept and many of the things that you are grappling with right now. So I'm hoping to put these in a little bit of a conceptual framework and we can have a conversation about them. So reference-based pricing is fee-for-service. It's not value-based care. It's a fee-for-service mechanism. So I recognize that reference-based pricing on its face is pretty easy to understand. It caps prices and brings the prices down immediately. The challenge from my perspective, a value-based care perspective, is that it gets us deeper into that fee-for-service column, into that mechanism that's broken, and has the potential in a short-term step to cause more harm than good if our goal is to get to the right side of that slide and get us out of the fee-for-service system. Sure, in the short term, it would bring down price, definitely. But it does perpetuate that perverse incentive. For a Vermont example, a great example of getting more to total cost of care or capitated models is the fixed prospective payment that exists today in Medicaid. That's an excellent example. And Vermont not only should be proud of that, but I think it's something that I would like to see us continue and deepen work in that space. My recommendation is the concept of global budgets and total cost of care contracts. Those two mechanisms together would allow for changes in prices, but also coordinated care and quality. So let's talk for a second about hospital global budgets. Hospital global budgets could provide hospitals and communities essential support required. It also is an option that could be and should be very attractive to payers because it helps manage that ongoing struggle between patient volume and utilization. It is possible within a global budget that a payer could pay a higher cost per admission, but when the incentive is on the outcome to reduce overall admissions and readmissions, cost will come down on the aggregate. Additionally, you'd see further investment in community health because the shared savings that comes from global budgets would be used to invest in the services that patients need. Yes, sir.
Can you go back and repeat exactly what you said one more time because it was unlocked?
Yes. So global budgets can provide essential supports for the community. The approach can be and should be attractive to payers because it helps manage that ongoing struggle between volume and utilization. So it is possible, I want to be quite frank and transparent, that a payer could pay more per admission in a global budget if you're measuring in that fee for service way, because don't forget, no matter what we do, we're not eliminating that administrative burden of billing yet, because you still have to have something to compare it to, right? So you would still need your healthcare organizations to bill, at least initially. So that per admission, but the target or the goal in a global budget would be to reduce overall admissions and readmissions, which would bring down the overall cost. The additional benefit could be and would be seen by community-based providers because your healthcare entities would be using data to understand their population and say, oh, over the course of this year, we realized that the patients that were coming in the door, whether it's in a primary care fashion or in a specialty office or within a hospital, required more long-term care, more mental health, more substance use than we had access to. So with the dollars in our global budget, we're now gonna in partner with this organization over here to make sure that in the next year, those things are covered. And so that's the mechanisms within global budgets. It allows for the flexibility on a year-to-year basis to determine what the patient population needs and then invest in those particular areas. Total cost of care contracts can act in a similar manner. So you can have a hospital global budget and a total cost of care contract for, let's say, primary care. And it provides incentives for coordinated and quality care. So if you do it just in the hospital space and you don't do it in the primary care space, the incentives aren't aligned. Or vice versa, same thing, if you do it just in the primary care space and not in the hospital space. We need the whole system working together, moving in the same direction. So that we're paying on that outcome, not on the volume. Incentivizing getting care to the right location of care. This also allows for us to get, I sort of oftentimes feel changed by the fee-for-service system. I think about all the innovations we could do in home-based care. If you Google or think about this, you're going to hear about the home hospital. I'm not talking about hospital at home. That could be something, but I'm talking about, what could we do for patients through like home-based phlebotomy, or what could we do in an infusion space, or what could we do that's expanded outside of what our VNAs are getting reimbursed for, because don't forget, they're also held down by the fee-for-service system. What could we do in that space? There could be dollars that would allow for us to think about investments, new programs, new services, try them, and then build them into our delivery system. Right now, we don't get incented to do that. And quite frankly, the further that we deepen fee-for-service, there's no incentive to innovate in that space. So to all of you, why wouldn't I recommend you bring the prices down immediately in reference-based pricing? Why wouldn't I recommend that you do that as an intermediate
Now you're
step?
gonna tell us we're doing the wrong thing.
Well,
But it's okay.
I'm gonna provide some information, and I actually hope that we have a conversation about it.
Okay, good.
So reference-based pricing and value-based care have different approaches. So if the goal is bring the price down only, that's what reference-based pricing would do. If the goal is really to get further to the right of that slide and think about how we change the delivery system, I worry that we're not nimble enough to go into a reference-based price to transition to a different model. So you run the risk of incentivizing more volume. You run the risk of provider organizations and hospitals increasing volumes, right? Think about where you're incenting it. You run the risk of deepening the cost shift. Services like the ones that I've been building over the last 2 years become at risk of elimination or cuts. So things like chronic disease management, care management service, non-billable care, right? That we're investing in to provide to manage chronic illness, a program that we have in our emergency departments called Working to Reduce Readmissions is not one solely for patients of the UVM Health Network. We're looking at patients who are utilizing EDs, who really we need to think about getting them back into wherever services and communities they live and they want to receive care. Those types of coordination are not reimbursed in a fee-for-service system. And if you bring the price down too much, too quickly, organizations have to figure out where to make cuts. So you could argue that that's administrative burden. I would argue that we're providing necessary care coordination as are others. And that's ultimately the care you want to incent. You want to incent coordinated care, not fractured widget-based pricing. If you reduce the cost to the point where you can't compensate the provider and nursing workforce at a competitive wage anymore, we are in a national market. That may have shifted and be different post-COVID, but that is the truth. I thought that I understood workforce crisis in the greater Boston area. You all can laugh at me. I did not until I came here. It is a true issue. And I worry that we could jeopardize the excellent doctors and nurses that we have here and advanced care providers. So reference-based pricing and global budgets have similar goals. But only global budgets build in the incentives that actually achieve those goals. When implementing reference-based pricing, I'm going to talk to you now a little bit about the risk adjustment elements that you would need to consider to do this. You're going to have to think about how you would adapt to supply, industry demand, and potentially any shifts or shocks to the system. You can't set a price without thinking about the patient population that you're setting those prices for. So I'm just going to give an example. Depending on the patient, I'll use a hip replacement and take it out of the Vermont market a second in your head and think about another part of the country where you may have access to ambulatory surgery centers more readily, as well as hospitals. You have a patient that has multiple chronic conditions. The likelihood of that patient getting their procedure in a lower cost of care setting in that ambulatory surgery center is low. The surgery center, quite frankly, might not do it because there's a risk of complication. There's a risk that that patient might need the hospital-based services. You set a price that's the same, then the hospital that requires a larger infrastructure to provide a surgery for more complex patients, it becomes more challenging for them to provide that care. So there's a really important component of risk adjustment in reference-based pricing. Secondly, reference-based prices should ideally reflect the quality of services for the outcome delivered. That's really hard. I understand that. Rewarding quality is difficult. Even defining the quality is difficult, but it's crucial to incent provider organizations so that they're not responding solely to price. So what would I instead recommend? I would recommend an immediate transition to total cost of care contracts with a transition to global budgets. Total cost of care contracts allow for more flexibility to make changes, both on the payer and the provider side. A reduction of price is certainly a lever and a key component in a total cost of care contract, because you would need to figure out what that total cost of care is and how to manage under it, and reducing price is a piece of that. These contracts should and would also include financial targets and outcomes and quality. It aligns a payer and a provider incentive. So for example, a payer and a provider would use population data. So like, how does this work a little bit to determine who the population is? Then they would need to figure out what the right target is within that population. And then it's the payer, essentially, their risk is capped because they've already determined what they're willing to pay. And the provider organization has to manage to deliver high quality care. I don't want to leave here today without noting that both total cost of care.
I told them we could have 2 more people. 3 is too much.
Well, with their medical student, are you folks medical students from AHAC?
Yeah, you can come here.
Oh, not that. Okay, all right.
Thanks, your Adam.
Thank you, Al. We're good.
So I do want to note that total cost of care and global budgets require data And to be specific, I'm referring to claims data, unlike clinical data. Claims data provide a longitudinal record of patient encounters across the healthcare system. So even think about a patient if they go on vacation in Florida and they go to an emergency department, or they go to visit their daughter in California and need to go to urgent care. And the reason why that's important, so it's all outpatient visits, it's prescriptions, it's diagnostic procedures, is because sharing this type of data allows providers to have a comprehensive view and allow for better population health management. Clinical data is important, but sharing the claims data is invaluable. And I just want to make sure that you all understand that piece. So in closing, I really believe that we are all in this together. I think our families and communities and neighbors are depending on us. And I do believe that we have the ability to change this together.
Thank you. Obviously, we all hear the expertise that's sitting in your chair. I mean, thank you for the expertise that you bring to the conversation. It's really appreciated. And understanding our time crunch, I'm going to take a few more minutes for folks to ask questions. I do want to make a comment going into this because we've been hearing about the silver bullet. Not really the silver bullet, but we've been hearing how important reference-based pricing is to reducing costs. And we understand also the severe crisis that we're in, the cost crisis that we're in. We've heard a lot of support for reference-based pricing for that reason, that we can enter it quicker, perhaps. We do have total cost of care and global budgeting in our bill. And what you're saying may nuance and help us improve the language to send us in the direction that will provide services without increasing costs. So having your written testimony will be really important. So I'll start off with a short question, but the assumption that once you go to reference-based pricing, we're going to see increased utilization. I think we're already seeing that in some ways. I mean, many hospitals using reference-based pricing, and then we're seeing increased utilization. I don't know if we can link those. I don't know if it's linear or not, but do you have a sense of that?
Yeah, I mean, we've seen historic utilization. Post-COVID, there has been an increase in utilization nationwide. We're seeing that everywhere, and an increase in acuity. My concern is that it's just on that. If you're solely fixated on the price only and you break just the price down, and we don't think about the other pieces of it, and we're not risk adjusting that work,
Yes.
you don't have an incentive the incentive isn't there to reduce the utilization.
Good. So this is why doing it out of context and doing it for just one group makes zero sense unless you're putting a framework in place.
Correct.
Now, that's where I begin to feel a little more comfortable as we're developing our bill. Senator.
Yeah, it sounds like I've had a vacation from this committee for 4 years.
Yes.
Something like that. That we were moving towards global budgeting or total cost of care. And this year's panacea, the silver bullet, is reference-based pricing. It started with a couple of our public unions that are it's a driving cost in education, it's a driving cost, in state government. And I see where it makes total sense. There is a base cost. And if we cut back on what you get paid for each service, if you're not covering your base costs, you're going to have to provide that service more often to make ends meet. So it is in some ways self-defeating. But if we focus on community-based health so that you limit hospital use, which is the most expensive, then overall we will get healthier people at lower cost.
Yeah. Yes. And we have been in a fee-for-service system for decades.
Yeah.
Right? And what does that do? That incents building hospitals and emergency rooms, and we need hospitals. We will always need hospitals. So around 2016, 2017, there was a full page New York Times ad taken out by Mount Sinai. Does anybody know this? I can send you the picture of it. It says, if our beds are filled, we have failed. And they were making a statement about value-based care,
That's right.
right?
Send it to us.
I will send it to you. It's a great slide.
Yes, we'll put it on our bulletin board.
We will always need hospital beds. There's always a reason for emergency care. I'm not proposing in any way that we eliminate hospitals. But we have not had a system that incentivizes us building and supporting this other types of services, the other sites of care. And I don't see reference-based pricing as getting us there. As an intermediate step, I am worried or concerned in some way that it just would deepen the broken pieces of it and not move to fixing it.
Have you seen how it's, you've looked at the bill that we have or not?
I have looked at the bill.
Yeah, looked at. So there may be some linkages we can make between the planning process and including within the planning process, the goal for capitation, the right care at the right time and right place. We put that in to the planning process. I mean, so there are goals in the bill that move us toward global budgeting. But I really appreciate your comments on this. It helps us greatly.
Is anyone inventorying? Do we have adequate non-hospital facilities
167
to do?
Act 167.
Your favorite. That's your favorite. I love it.
I just don't know.
2022. Thank you.
Okay.
Um,
Go ahead.
thank you. Well, thank you for your presentation. It was very interesting and enlightening. And we are in a crisis. And there, one particular hospital is extremely expensive. And it seems as though, if we're thinking in a binary, it's not helpful. It seems as though we need all the tools in the toolbox to try to fix the situation. So I appreciate everything you said. And it seems as though we need to be super creative and act with alacrity to staunch the bleed and fix the problems that are, just exacerbating just about everything in the state right now, all the problems that we have. So I'm trying to keep an open mind and so bring everything to the table.
I think that that's an excellent approach. It is a yes and situation. Yeah. It is a we.
And we need everyone on the same page. Yeah, so right now, we have folks who are really ahead and understand, not using that in the ahead model, but in front of others. And that includes what UVM is doing. I understand that. It also includes what is happening with Blueprint folks who understand the need to keep moving and SASH and home visiting choices for care, all those things that are in front of where policies are. And it doesn't help, it doesn't help to have the lead hiker go off and leave everyone else behind. Then you're going to have an accident behind, which we're seeing. So we need to get people to play catch up. We need catch up, and hopefully we can do that. And your testimony will help us make that happen. Really, very helpful. Senator Douglas or Senator Hart, you questions? Is it clear? Okay. All right. Good.
Thank you.
Thank you. Can't tell you how much we appreciate it. We may drag you back in another time. You never know. Your expertise is welcome very much.
Thank you. I appreciate the time today. I'm happy to come back anytime. I will get written testimony to you by the end of the day. Thank you. Thank you.
We are moving ahead.
Yeah, well, that acronym does challenge the use of that word. Thank you.
All right, good. We're going to keep moving. And we have folks from the Vermont Medical, Jessica here from Vermont Medical Society, and we're still looking at our bill, and they're hearing things that will influence our decisions as we walk through the bill with Jen going forward. Come on up and just welcome to the medical students who are here. Thank you for being here with, it's with AHEC, I guess, right? Good. What year are you?
Fourth years.
Oh, wow.
Graduate.
Have we had the White Coat Day yet? No.
First year.
Oh, yeah, oh, yeah, okay. Okay. No, I mean internship.
Yeah, match day.
Match day.
Coming up in
Match day.
like 10 days. Yeah, 9 days. So we're gearing up.
Terrific. Well, good luck with that.
Thank you.
Maybe you'll stay in Vermont.
Yeah, hopefully.
Good. Welcome.
Thank you. Thanks very much for having me. I'm Jessa Barnard, the Executive Director of the Vermont Medical Society on behalf of our physician and PA members. Speaking to the committee bill, I already testified back in February on your draft, so I am doing my best not to repeat my comments. And I know you are also not the Appropriations Committee, so I will not go into detail except to say one more time that unless we address the 2026 gap in primary care funding, we have a real concern with moving ahead with any health reform goals and having
Understood.
primary care practices there to be the face of our system.
The gap, this is the people that were getting the global payments that aren't.
This is the people who would be getting payments from the ACO and Blueprints that have no currently and no funding source until or unless we join the AHEAD model. So House Healthcare is well aware of this. They put these in their recommendations to the House Appropriations Committee. So it is moving forward, potentially with some support, but we just want your committee to know it will also be coming your way. And I'm thrilled to be following Jessica because what I'm going to say next segues very well with what she was saying, which is we not only need the funding, but we need some structure to distribute that funding and to keep primary care not only receiving adequate reimbursement, but in a payment reform model. Because of the structure also partly goes away without the ACO. And I was mirroring almost exactly what she said, which is all this work around reference-based pricing is really still in our fee-for-service model. But primary care in Vermont has been moving well away from that with our Blueprint payments, with the ACO payments, especially for the independent practices who have been in the comprehensive payment reform payment. That's really pretty far down that line of capitation in her range there. So the reason I'm bringing this up in your bill is that we're asking, while the appropriations requests are moving, hopefully in the House, hopefully coming to you, we also request some language in your bill around paying alternative payment models to primary care. It could go, you already have a section that talks a little bit about it. It could go there. Structurally, I think it could go really anywhere. But we are asking that the Agency of Human Services, and I say this really lives in the Agency of Human Services because they have done the most work already in our view with the Blueprint and with the ACO in how these payments can flow to primary care practices, to develop by January 1 of 2026 a per member per month payment rate and methodology just to maintain the 2025 funding rate. So basically keep what we have in place currently for 2026. Working with Human Services, the Agency of Human Services on how to distribute that funding. But then we'd really like to see language growing that by January 1st, 2027, the Agency of Human Services consult with stakeholders, including primary care providers, associations, administrators, and healthcare finance experts to develop an alternative payment program for primary care practices, which could include a per member per month or a capitated methodology. Could apply to adult and pediatric patients and shall support practices, ideally to at least the same extent as the primary care AHEAD program would. The reason I think this language is important, if you're moving to AHEAD, we have to be doing this work anyway, and we would like this to be sort of all payer work of how not only would Medicare be funding through AHEAD, but how does Medicaid and private payers align with that. But we all know there is some chance AHEAD may not be happening. We think this is really important work one way or the other, and we'd like to really see a commitment from all the parties in the state working towards how can we support primary care and alternative payments by 2027. So we would hope that could find a home in the bill. Then my other comments are sort of walking through the bill as written. We have some specific feedback on different sections. I don't think I need to reiterate, we agree with the comments you've already heard just about the concern with the timeline to reference-based pricing in section 1. And also support that be pilots. Under the reference-based pricing, section 2, reference-based pricing sections, we do have some questions, and I think I heard a little bit of this question also from the Green Mountain Care Board today about which payers this pilot or program would apply to. Is this only regulated commercial payers? Is it also ERISA plan? Because that obviously has a big impact on how it affects different providers as well. There is a language in the bill about Green Mountain Care Board consulting with payers to develop the model. We believe it's important that they also consult with providers. And
we have heard.
and you have heard that from Boz, and I also support Boz's comments. They put forward some suggested legislative guardrails that could trigger either knowing when it is successful or causing harm. So what are the checkbacks to know this is working or this is causing unintended consequences? I'm going to go into, I don't think you've heard as much about this. So this is section E2, under section 2, E2. There is a reference to actually allowing a differential or departing from Medicare rates. This is very important in VMS's perspective, especially if we're talking about professional services, not just inpatient services. And maybe this is why the language is there. I don't know, but I just want to highlight it for the committee. The professional fee schedule, the Medicaid Vermont professional fee schedule is basically a reference-based model. It is based on Medicare. And the problem we have seen year over year in professional services is that Medicare is cutting that fee schedule. It's decreased. We're actually in our 5th year in a row in receiving cuts. Okay.
That's from Mount Walker.
Oh. Okay.
Let's look and think of it's yarn.
Yeah. That's coming from home. You know what it is.
Oh, damn.
Ah, okay.
But I got my package from yesterday.
Is this what we ordered?
Yes.
Ah, okay. It's the things with the logos on.
All right, okay, cool, all right.
So Medicare.
Medicare in their professional fee schedule. So for example, physician services, psychology services, medical services, that fee schedule has been cut. Yes, and in fact, it's declined 33% since 2001. So if we are benchmarking to a Medicare fee schedule that is decreasing every year, that is going to be a problem. I don't believe that is the same issue for hospital inpatient Medicare rates, but it is for the professional rates. So we actually think that it'd be important to have explicit language around being able to separate from Medicare rates in the case Medicare rates are decreased, and ideally actually including an inflationary adjustment factor. For example, what we've asked for in our Medicaid fee schedule is the Medicare Economic Index, which is an index of inflation that CMS publishes every year of medical inflation.
What's it called?
The Medicare Economic Index. And it's kind of on the middle of page 2 on my testimony, including a link to where you find it from CMS.
Section 2.
Yes. And then, so that's a little bit related to our next comment around expanding the program from hospital services to non-hospital services. I would say we have a lot of questions about the feasibility of doing that at this time. I would actually recommend ideally we don't sort of explicitly move to that until we see how it's at least working in hospital services. If there is a desire to at least include language around it, we think there needs to be a lot more specificity. I mean, that's a whole range of services. We're not even sure the intent of how broad it is. Does it include mental health services, dental services, just primary care, specialty care? How does that information flow to the Green Mountain Care Board about what those services are even currently being paid? Those are not services that or entities, providers that the Green Mountain Care Board currently regulates or has information about. And how would they set a benchmark? How would we know what that benchmark should be? So I just think it's very complicated. And for that reason, perhaps should be a second phase once we have learned from how it works with hospitals. We do support language around increasing a reference-based price for primary care services. But again, think at this point, we would ideally that should start with hospital primary care services. Or any other service we want hospitals to we want hospitals to provide some sorts of services. So that currently that language actually says it's only for non-hospital based primary care services. We think it should be applied to all locations of primary care.
This is
E4.
E4.
Oh, yeah, okay, it's like line 20.
Something like that.
Yeah. 20. Okay.
Yeah, exactly.
Okay.
Yeah.
Do
Now, moving to section 3, I have you've heard a lot of testimony already about the data on administrative costs and salaries. Our comment is specific to adding in paragraph 8, information on clinical leadership, salaries. I do not see that term defined already in Green Mountain Care Board budget guidance. Maybe I've missed it, which is definitely possible. What's that?
No, just wondering, what is it?
What is it? I mean, you've already heard this from Bob, but many clinical leaders are people who also provide a lot of patient care, include physician, nursing leaders, leaders of departments, programs, units. So I would suggest perhaps sticking with existing definitions and terms Green Mountain Care Board already uses in their guidance, rather than adding in a new term around clinical leadership. Okay. Section 4 under budget review. There is language around incentivizing primary care and preventive services. We support that, though we believe hospitals should have incentives to invest in the spectrum of primary preventive services, regardless of whether they're provided by the hospital or non-hospital providers. We also think it could be helpful to provide a little more specificity around what would this mean, what we're talking about with incentives. For example, we would support an approach where, for example, if there's revenue derived from primary care, mental health, substance use disorder services, or really any other list this committee wants to include in that list, that wouldn't be counted towards hospital net patient revenue or total cost of care targets developed. Things that we want more of, sometimes there are services we actually want to see volume in that those could be exempt from, again, either net patient revenue if that metric remains long-term or total cost of care. So we want to actually see that go up within our our cost of care.
That's very helpful.
We also recommend, and I kind of referenced this earlier, but that any reference-based price methodology that's developed, and that would include such services, be set in a benchmark to encourage the delivery of such services. We'd be very concerned if, say, a reference-based price that includes primary care or mental health services that is actually a reduction in payment for those services. There's a E1 is about quality measures. We support consistent, strong quality measures. We would recommend that be coordinated with work already being done by the Vermont Program for Quality in Healthcare and also be aligned with the state healthcare delivery plan and advisory committee. And so we have some suggested wording that just reframes it a little bit, that the board would consult with BPQ and align with the goals of the state healthcare delivery plan and establishing measures for hospital cost, quality, and access. We have some concern in section 6 under the delivery plan. There are 2 paragraphs that reference the plan ensuring access to certain types of healthcare services. Unfortunately, while it might be a goal to have access to such services, I'm not sure the plan itself can ensure access to services. There's already what I think is a little more nuanced language later on about reviewing appropriate allocation of healthcare services and identifying gaps in care. So I'm actually not sure those 2 paragraphs are really needed, or at least maybe look at the wording around ensuring access to services. And then we support, Voz already commented on this. We support their approach, and I think you'll be hearing maybe from some other stakeholders with written comments as well, identifying specific organizations or sectors that should be represented on that committee. I actually suggest you might want to look at Act 26 of 2019 that created the Rural Health Services Task Force that was led by the Green Mountain Care Board. It has some nice language with X entity shall appoint Y person, and then it kind of goes down to the list of, so just as an example of what that can look like. We support section 9, which asks about retaining some of the ACO capabilities. We just suggest some rewording on this. I suggest that work primarily be housed in the Agency of Human Services. Right now it references the Blueprint for Health. We think that work is broader and certainly should include DEVA, really the whole Agency of Human Services, who's worked on a lot of payment reform. And it also references electronic health records, but the work has been broader, I would say more as quality data measurement and reporting, not just specific to electronic health records. So that's some of the capabilities we would like to see examined for retention, along with, of course, my earlier comment around payment reform models for primary care. My last comment, I already stated this back on the draft, but I will just say again, we do have concern with significant resources going into policy and regulatory staffing when direct primary care and other practices are really struggling. We would just really ask the committee take a hard look at what can be reinvested or reallocated from things like overseeing the ACO rather than additional funding. If there's any additional funding, we ask that it go to any one of the direct care providers who we know are asking you for a lot of support this year. Thank you very much. I really appreciate your time.
Oh, thank you. This is comprehensive. We appreciate it. And well, it's already going into the hopper.
Thank you so much. Really appreciate it.
Thank you. And so we're going to move to Beth Anderson, who is here. Oh, there you were hidden behind. And so we have Beth and then Mike Fisher, and we should be in good time frame. Thank you.
Thanks for having me.
Now you have freaking.
I will be fast
Good.
and I will talk slowly.
Okay. Yeah.
Okay, I'm Beth Anderson. I'm the CEO and president of Vital. I know you've seen me a few times, so I'll not go into what we do, but we are the health information exchange for the state. I just wanted to provide some information specific to section 8 of the proposed language. So that is the language around interoperability. Specifically, the concepts that are addressed in section 8 include concepts that are specific to Vital and the work of the health information exchange and interoperability, and concepts that are specific to the Unified Health Database, which is the goal of getting data in addition to the clinical data, other information about patient care and individuals across the state to do analytics and reporting under AHS. So what I'd like to propose is, or respectfully requested, a shift in the language to clarify the difference in the two. And I think that could be addressed in one of two ways. One would be just to make the language specific about the Unified Health Database and the work that is intended to advance, or separate a separate section. So there's one specific to the Unified Health Database and one specific to the HIE work around interoperability. The three under subsection B that are specifically the more confusing or more specific to Vital are 5, 6, and 10. So 6 are specific around interoperability with EHRs, electronic health records, which is the work that we've been doing for years. 6 is specific to work around social determinants of health or social drivers for health data, which is data we are working to get into the HIV now. It may end up in both spaces, but that is absolutely work that we are doing now that we then shared with the Unified Health Database. And 10 talks about some projects we have underway, specifically with the WIC, moving into children's
Slow down,
at VGH.
please slow down.
Yeah.
And we have your testimony, so give us the
punch.
yeah, please.
Yep. So those are my points. The only other point I'd like to make is for subsection C, which talks about the sharing of the data or how it should be made available. Many of the data sets that are in the HIE or would be in the Unified Health Database will have some specific restrictions to how they might be able to use HIPAA data use agreements. So I think it would be good. I'd like to respectfully request some language we put in there that any decisions to share the data be aligned with restrictions that exist or agreements in our place.
You have a sentence there that helps, as allowed by the data use agreements in place for each data set. That works.
That is sweet, but that is the summary of my comments.
Questions? We're good. Thank you. Thank you for taking a look at it and bringing us the recommendations are really helpful. And we have last on this list, but not least, is the healthcare advocate. And Mike, you're here. Sorry you're sick. Oh, you have a good person to sit in the chair for you and with you.
Yes.
Why don't you introduce yourselves for the record and then we'll hear what you have to say.
Yeah, Mike Fisher, healthcare advocate.
And we don't have it in writing yet, so but we need whatever, bullet points and writing, that'd be great.
Sam, go ahead.
Do you have it?
Yeah.
Okay, refresh. Yep, we have it. Thank you. Go ahead.
So Sam, did you introduce yourself? I'm sorry, I didn't hear.
Yeah, Sam Weish, I'm a health policy analyst with a healthcare advocate. I've been there for about 4 years. I think it's my second time in this committee in Seattle.
Yeah.
So senators, I'll start off with a high level statement and then Sam's going to plug us through. We do have comments for point section by section and we'll fly a little bit high, but I think there's a few things we want to make sure we get across. But on a high level, I want to echo something that I heard the chair say earlier. I want to bring us back to it. I have a hard time at this moment reconciling the important need to go slow and careful to make sure we get it right. And I'll just put it, and the 24 hospital budget actuals that just came out in front of the Green Mountain Care Board. What I mean to say is we have a significant challenge that's playing out now in our healthcare system. And so I'm not going to suggest that we go faster than we have to. We need to go slow to get it right. But I have a real fear.
Mike, we get it. We understand. And so just go to the bill for us because we are so crunched right now. And I do appreciate that. I know the thinking that's going on and I understand your commitment. But it would be helpful to get there.
Okay. Sam, why don't you go ahead and start plugging through?
Okay, so starting with section 1, I think what you'll hear generally is that we support a lot of these sections, but have some recommended changes.
Okay.
Or some updates, clarifications, things strengthening. So our office is concerned about doing global budgets based on current pricing and current variation. So we really I think this is contemplated in the bill, but it could be a little bit clearer that we need to get prices to a stable level before we do global budgets. And I think that's what's been discussed, but I wanted to make that clear. And if reference-based pricing is done via pilot, one or several hospitals, we really think, I think you've heard from Marilyn Bartlett, it needs to be all facility services. So otherwise it can blow out on the other side. And I do think there's value in some type of utilization benchmark to prevent against high utilization just leading to higher costs, because as we know, costs are a combination of price and utilization. And I think it's very clear in Vermont that the principal issue we have is the prices at some hospitals in particular. So I'll say at a high level on that. So section 2, I think you've heard, I'll add our voice to the chorus of folks saying we need provider rate setting, not payer rate setting.
Got it.
We really need to be clear on that. I also think it should be clear that the board consult with state experts that have already done this type of work. I know that they're considering that, or I believe that they're considering that already, but I think that should be codified into language because we really don't want to reinvent the wheel. I do think there are unique features of Vermont's healthcare system that, of course, we need to accommodate in any kind of methodology that the board considers, but we don't need to reinvent the wheel. We frankly don't have time to reinvent the wheel. And we'd like to be a part of that group as well.
Yes, that's an oversight. I mean, no, it's not an oversight. It's that those representatives were put together pretty hastily.
No problem.
Yeah, at midnight, maybe before.
And Mike, please jump in if I'm just leading us astray, or you want to add anything.
No, all good.
In section 3, so I do think it'd be useful. I know you'll hear from the board and perhaps they'll speak to this. I think it's important to clarify what we mean by uniform chart of accounts. As you all know, their critical access hospitals are paid very differently than, say, how UVM is paid. I think we support the intention. We have a lot of concerns that we've raised with the board about, compliance with reporting and uniform reporting. That's not to, criticize any particular hospital, but I think there does really need to be some work about standardizing what is reported using the same definitions. Because if we're not able to trust that we're looking at apples to apples comparisons to the degree that's possible, we're going to be making, and the board will be making decisions based on inaccurate or incomplete data. And I know they don't want to do that either. So just a call for also adding in some language around compliance with hospital, with uniform reporting, in addition to the clarifying the system accounts, what we mean by that. Section 4. So we use for all these sections, these are just kind of clarifications. I just want to make that clear. Section 4A7, it's on page 9. This talks about it's developing incentives for hospitals. This might be a bit controversial, candidly. We think this is a place where the state needs to lead. I think we have really tried having hospitals lead this work, and I think oftentimes we've asked hospitals really to boil the ocean, to treat sick patients and to do community health work, to do population health work. They're in a very, as Mike alluded to, a lot of our hospitals are really in a financially precarious place, and I'm not sure if this is the time to ask them to do more in that area. I think that's really an area where the state needs to step in to invest in these community programs. Then I think it has broad support like SASH and Blueprint. Having the hospitals be a medium for that, I'm not sure is the most efficient and effective way to do that.
Oh. Okay, so the language might change there anyway, based on testimony, review incentives.
Instead of.
Right. So it's, yeah, I think that, go ahead. I got it. I hear what you're saying. I think the intent might be different from what I'm hearing, so we need to clarify language.
Okay, great.
Yeah, thanks.
We do have some suggested language about as a part of the state healthcare delivery plan, which we support. We do think there needs to be some clear goals, and they need to be enforceable. I think we've all been a part of groups that develop really great plans that don't always have, targets. I mean, a difference between a target and something that's enforceable. We do think to the extent possible that we should have a real goal of what we're going towards. Like, we need to get to X price level by Y date.
Yeah, include, so the financial information as well as the care access becomes important.
Right. Got it. Totally. And as a part of that plan, we would recommend including some language about aligning variable pay or bonuses with goals identified in the plan. Because I think you've heard testimony from others that I think from Mark Hangsler at the board this morning, I was listening to it as I was driving over the gap from where I live in Moncton. So I believe what I heard him say is that there's concerns about alignment between some of the incentives and what we want as a state. So I think it's useful to clarify that. And Mike, I'll turn to you about section 5.
Sure. When I do section 5, first off, appreciation for section 5. I think we feel like it's very important. And we just want to make sure the board has the authority to really do the work. And so we're suggesting an additional component of that and to require the board to conduct an evaluation of whether a health network is serving the public good, and if not, to take corrective action. We've been watching this thing for a long time, and we think it's important that the board have the authority and the direction to do this work.
What value is it to Vermont? Yeah.
Yes.
So section 6 and section 7, we also support these with a few recommended changes. We think it makes sense to select either the board or AHS, and I imagine they'll testify to this. We have concerns about joint leadership in that area. I can understand the impulse to do that, but I do think it makes sense to clarify that. And I don't believe we have a strong position
So
on who that is.
go ahead.
Yeah.
You can tell us, what is your suggestion for that?
Mike, do you have a specific? I don't know.
It's
No,
okay.
just
It's
to
okay.
say it here,
We're working on it.
Yeah.
We're working on it.
just if I could just say it really clearly, Madam Chair, we're not offering a suggestion about who does the work. We're suggesting that you define one entity to be lead. Tell them to consult with each other, that's fine. But having watched this for a little while, please don't tell them to work collaboratively to develop a plan. I think one part of state government needs to be responsible for it.
Got it. Thank you.
And one other piece on this section that I would just mention is, selfishly, like, we would like to be a part of that process and incorporating community members. And I believe that's a part of the advisory section. I'm not sure. if
Yes,
that's
it
gonna
is.
happen.
Yeah, we got it.
But just.
And I think Mike had mentioned this earlier, so that's important to reinforce. Thank you.
I know I have 4 minutes. I will, so section 8, we're almost through. We support this. We have a couple, we've been a part of conversations with the board, Vital, and AHS, and I think we're pretty close to agreement. Just a couple things that I want to highlight. It's really, Eric Schulteis on our team has done some great work on this, so I don't want to make it seem like I'm taking credit for work he did. But thank you to him. We do recommend claims data integration be permissive rather than mandatory, depending on the linkage of clinical efficacy and patient safety. I know that's confusing.
That might be problematic.
Okay.
And I'll tell you that right up front.
Okay.
Okay.
And we support maintaining the best practices from privacy and security. There's a line in there.
Right.
Section 8. Section 9. Oh.
Hey, Sam, let me jump.
Yeah,
Let me,
go ahead.
let me jump in. It's totally fine if our suggestion here is, I understand our suggestion here might not fly, but I just want to say, we understand that this is being tested, that there is a test underway to understand the efficacy, to understand the benefit. And so we're just suggesting not get in front of that test, let that test play out and have the practice be informed by the outcome.
Okay, thank you. Well, we will take that into consideration.
So section 9, we have a bit of a concern about expending resources to retain some of these efforts, given the challenges that we have. And we have some concerns about how much value there is in trying to retain that analytics work. We don't want to lose things that are important, that are valuable to providers, but totally hear that. But I do worry about like how much time, money, given everything that's going on, I do think there's going to be a need for prioritization.
Yeah,
So that, I just wanted to express that.
I get it.
Yeah.
No, we get it. And the difficult thing is accessing the data, which
Yeah.
belongs to the payers. And not being allowed to have that is difficult. So it will require some negotiation and some work outside of this building. But it is so important that we not lose the work that was done. And it's unfortunate that the data was not allowed to be more accessible in the first place. I think that was a mistake, my opinion, but you know, whatever that.
Madam Chair, just one quick comment about resources for the board.
Sure.
Yes, we support what is framed in the bill, but I just want to say out loud that from our perspective, the underfunding of the board has not been good for board staff. It's not been good for regulated entities either. When you have people who are burning out because the job is just undoable, they last for a year or two, and we have somebody else needing to come in and learn, and that has created more instability in the regulatory process. So that's a little bit of a response to the hospital association's pushback on this. We think it will be better for the hospitals to have a stable hospital budget staff, and so we and better for the public too. So we support the funding for the board.
Thank you for that comment. That's really helpful. All your comments have been very helpful. Appreciate it. And no promises, but
Of course.
obviously a lot here, and we'll certainly do what we can do.
Thank you.
Thank you.
Hopefully they go for time.
Thank you.
I don't know if there's, here we go. Perfect
Thank you.
timing. Couldn't be better timing.
Thank you.
Thank you very much, and hope you drive over the gap this fun.
Yeah, easy.
It was a good day.
Yeah. Dropped my kid off, went over. Great.
Okay. Yes. Do you have it choreographed? I know Diane is the choreographer.
He will be doing the rest of the sections, 5, 6, 7, 8,
Oh,
9, 10, 11.
Perfect. And we don't have anything in writing on that, but if we can get something that would, would be great. Thank you for being here, Chair Faulkner. And as I said to the other folks, and I'll say it again, we know that this is time out of very important work that's going on across the street. Appreciate you being here.
For all you as well, and thank you for having me again and giving us so much time this year. Just for the record, my name is Owen Foster, and I'm the chair of the Green Mountain. Okay. So
And our other folks up on Zoom,
I,
do we have? Is Lindsay Kill or Mike Michelle Sawyer, the others here?
don't know the answer.
Or is it Owen Foster? No, it's Owen Foster. Good. All right.
We figured we'd streamline this for the time constraints.
Awesome.
And we'll always come back.
Awesome.
So I am prepared, testify more on sections 5, 6, and 7.
Yeah.
We would like to send in, something written on some of the other sections as a little bit more work being done. I can speak to a high level. But I want to focus on 5, 6, and 7 and, take the rest of it here. And I understand you've been through 1 through 4 this morning.
We did, and we did hear a little bit about adaptive, so it's
Great.
it's good. Okay.
So I'll just take an order then at that please and committee. So section 5, hospital network financial operations. We support this provision. We have a network, one network that would qualify under this provision, which relates to UVM Health Network. Currently, we don't have direct authorities over a network. The network has significant operations and significant expenses, several hundreds of millions of dollars in shared services every single year. We indirectly regulate that through review of the hospital budgets. And the hospital budgets are the basis from which the network operations are financed. So it is indirect, and we've never really had a problem, to my knowledge, getting information from the network. But this gives us the authority to take a deeper look at how that's operating. To give you a sense of scale and scope, a couple $100 million network operation is, I believe the size of the health network operation is larger than our second largest hospital in the state of Vermont. So very, very, very significant operation investment money. And the goal of the network, or a goal, is for shared services and economies of scale and efficiencies. And in the cost expense structure, we haven't seen that pull through quite like we might hope. So this gives us that ability to look at that. So we are supportive. There's also been some discussion about whether or not there should be a study of how the network should operate, where the network should be placed. We think that would be beneficial. The only thing I would say is a permissive may review that would be appropriate. The reason I say that is the University of Vermont Health Network and the Care Board have been in discussions for several months now on some of the ongoing issues that are out there relating to budget enforcement. Fiscal year 23, UVM had a large $80 million budget overage. In fiscal year 24, there's another $53 million budget overage. And we have been engaged in a very positive discussion on how to deal with this in a way that's most productive for Vermonters. I've been very encouraged by the dialogue. I've been very encouraged by the engagement of their board leadership and by some of their managers in particular. We are hopeful that we come to a resolution of some of these issues and that would be public and reviewed in a regulatory process soon. We're not there, but that has been going on. So I don't know that it's necessary for us to be required to do that work. I think that the permissive would be appropriate given those broader discussions that are going on.
Okay, thank you for that. I think that's helpful for members of the committee to understand that there's work going on outside on this. Appreciate it.
Yes,
Appreciate the work you're doing. Thank you.
it's to be determined whether or not we're able to get all the way there, but there's been a lot of progress made dealing with what the budget overages are and how they could be handled. And as you know, first, UVM would need to agree to some of these things. We're not 100% of the way there. Second, they'd have to submit an application to the board. We have a public process. We have 5 board members. 3 people need to vote for it. The healthcare advocate has input, the public has input, and whether or not it would ultimately get approved if there's a submission, it's all to be determined. However, I am encouraged by the course of dialogue and productiveness of those.
Thank you.
Section 6, if there's no other questions on 5. Section 6 is a statewide healthcare delivery plan. We are very supportive of having a statewide plan. We think it is imperative that the state have a connectedness between all the various components of government that work in healthcare, DFR, AHS, the Care Board. And having a statewide vision would be beneficial. I have one comment for people's thoughts, which is whether or not it is better to have it at one agency and one agency would be responsible, or for the whole collective to be responsible. I'm not taking a position that one way is the right way or one way is the wrong way. There are pros and cons to either way. The Care Board is better for the Care Board to do it in the sense that we are independent and everything we do has to go through public process and public hearings. I think that's beneficial. At the same time, a statewide plan being responsive to the electorate has benefits as well. Additionally, having one person in charge and responsible, one entity may have benefits also, as opposed to who's responsible. So I'm just pointing out that that is something to think about. And I'm not taking a position what is right or wrong, just that.
You're the second person to put that responsibility right here. We'll take it.
It's all like this.
We'll take it. I'm sure we'll hear from others too.
But otherwise, I think that the design of the plan, the principles that are in here, the intent, I think that is all quite wise and prudent at this time.
So we've had your suggestion a while ago was to ensure that there are cost targets and included, and we've had that reinforced. So,
Yes.
yeah.
We may have a couple of line edits here and there that are minor that we'll send in through Ms. Harvey, but nothing major. The next section is section 7, the advisory committee. Again, we're supportive of having an advisory committee. The only question again is who exactly is responsible for it, who has to take on the workload, and the timing. The one comment I have is, to my eye, one of the things that we have not done as well as we can as a care board is trying to do too many things sometimes. We have too much on our plates and we do burn our people out, we burn our board members out, and we have difficulty managing everything. So it's just something to be cognizant of, and that's why we're really appreciative of all the positions and the financial investment the state has put in this bill. This committee put in the bill to help us deal with that. We can't, none of these things are a light switch. Below any of these, it's a massive amount of workload. It really is. Any reference space for all of it, it's a lot of work. So we appreciate the positions and just calling out that this is more work and we'll have to make sure we can manage it well.
Thanks. Thank you so much for your testimony. As we're thinking about this, putting this in place and the work of the Rebound Care Board is, and there seem to be some shifts being made. Is it all add-on work or is it work that might replace some other work that you're doing?
Yes and no. So, we do have a flow of work that ebbs and flows, and I'm always trying to find ways we can do things more efficiently so that we have less administrative burden on hospitals and people we regulate. Looking at the rate review process, trying to slim that up. Hospital budgets, smaller ones, compliant budgets, let's move them quickly and not invest so much. So yes, to some degree, this is work that's already being done. Some things will be freed up by others. But anything where there's more meetings and more work, there's agendas, there's slides for the meetings, there's the follow-up to the meetings. It's everything is a lot. And if you really look at what we're doing right now as a state, we have the regular core duties, which I would argue we are not sufficiently staffed for already. So that's just our day job. Then you have Act 167 transformation. That is a giant work stream. Then you have emergency response to situations that we're dealing with. That's a whole nother incredible crisis that we have to deal with now. Then we have the UVM work called UVM transformation work. That's a whole nother bucket. Then you have potentially the head model. Then you have reference-based pricing, then you have the statewide plan, then you have the advisory committee, then you have our normal work groups.
So what can we take out of this right now? Let's kind of.
Well, the truth is, some of the timelines in here, I think, help quite a bit, and that the statewide plan would be 2029, and I'm just raising this for, some of these, it might be good to make them permissive, just given the volume of work and the need to excel at execution. So I agree with all of these. Every one of these is really, really, really valuable and critical. Some of it will be on us to manage it and be able to do it. We all want to do all these things, and the resources, and when we get them, that will help us. So the timing, the permissiveness, and the resources. A couple of technical changes will come in draft language in a red line to Ms. Carby. Just one to flag on page 19, line 12, 13. Says the Green Mountain Care Board shall provide administrative, technical, and legal assistance to the advisory committee. Again, that's some additional work for the staff. But I'd point out just the legal piece. We can't give legal advice to not, it would lose privilege. So just one technical change.
Question there, I mean, because, one of the decision about that, and then the decision about who's in charge seem to go together.
Yeah.
And so is it the board or is it AHS? And that is the question.
Yeah.
I'll leave it there, but.
I don't think the AHS legal counsel could give legal advice to, once you go outside of your house, so to
Yep.
speak, you lose privilege.
Yes. That's
Legal
why I asked
counsel
it.
can't give legal advice to constituents.
You got it.
Yes.
You got it.
Right. So I have nothing else on that section. Section 8, I testified to this previously at a high level. I guess the right word is almost agnostic. We think it's a good idea, whether it's the right priority, whether there are different things to consider, such as the impact on whether the commercial insurers want to do it, whether there's privacy issues. Those are just the things that we flagged. We wouldn't oppose this. Just flagging the other considerations that are out there that are not necessarily ours, but we acknowledge others. And we may have a written comment on this as more in depth. Section 9, retaining accountable care organizations capabilities. I would not prioritize this work for the care board to really understand like the ROI on each thing that the ACO does would take a significant amount of work, and we'd have to get really involved in their granular operations, right? Like we look at a very high level. Are they improving access? Are they improving quality? Are they improving savings? How much is their budget? Is it appropriate? But like, does this work well? Does this work well? What's our return on this? Should we, like, that's not the level that we're in the regulatory space. I think it's valuable. I mean, we spent a ton of money on the operation. I would presume or hope, I presume that UVM, the parent organization to the ACO, and the ACO are doing this anyway. So it might be better suited for them to evaluate and report out on that. Otherwise, we're essentially doing some level of like service line or work stream audit. And I don't know that we have the capability necessarily.
Well, very good point. And I did have an opportunity to talk with ACO leadership about this, and it's difficult. It's a stretch. It's a strain where the data exists, the software to get the information into the data analytic. It's a real shame if we can't access this, but I'm not sure that this is the way to do it. I agree. Yeah.
It'd be great to salvage whatever we can out of the
It
investments
would.
we've made.
If you have any suggestions for language that can direct us to that,
Sure.
let us know. That it's disappointing to say the least.
Yeah, it hasn't worked out where I really wanted. So I think salvaging what we can is productive. And there are things that people, at least anecdotally, we hear people really find out.
There's some terrific people with that organization, and it's a shame.
There are many, and I
Good from ours.
think those workers will be retained in appropriate places. It's
Let's hope.
material things and some operations. So the next section, section 10, Green Mountain Care Board positions. I wanted to flag two things. So the ahead model is a giant unknown at this point because it is a complex model. We never know how these things are going to go. It's very hard to predict the future. It just is. We have signed the agreement, the care board, the governor, and the secretary of HS. The care board's vote was conditioned on 5 or 6 things that have to happen, or we have to exercise our termination right. One of those is adequate resources to do the work. And 3 board members supported signing the agreement, but there was concern about the ability to do the job and the ability to do it well, which is why, to get 3 votes, I made a motion to get the support for the positions. And that allowed us to get the 3 votes needed to have it out there. And the unknown is really, we have a change in administration, and there's been change at the federal level kind of across the world. And where this lands and where this sits and how it happens is still an unknown. There's been a blackout period since the administration's changed. And so we don't know exactly where they are quite yet. We're hoping to get further clarity on that soon. So the condition was 5 positions in this year for us to be able to do this work. So I would support that. It allows us to keep the ahead model as an option for the state to pursue if it's deemed the right approach. Additionally, the governor put 3 positions in his recommended budget, and then this would be 2 more. The other piece is to do the reference-based pricing work that was spoken about earlier. You have to create a methodology. You have to know what you're referencing to, what services, what service lines. You have to analyze like impact. You have to put it in guidance. You have to have stakeholders, feedback, insurers, the hospitals. You then have to operationalize it. You have to have rulemaking. There's a whole lot of steps that make that happen. And these positions would help us do that work. We can't do the work with our staff of 3 on health systems finance right now. So this would allow us to do current regulations and then do reference-based pricing, or if we're focusing on ahead, we'll focus on ahead. So we support that. And then the later positions are necessary to do the statewide plan, which we really do value at a high level, the critical to addition to the state's planning. And also for the global budgets that are recognized in this time frame. So I think this does give the state time to ramp up the resources to do that work. It's really hard to ask for positions when you're seeing the healthcare system in such dire financial straits. The 2 things I would say about that are, if we're going to do additional work that we think is beneficial, it takes an investment. The question is just whether or not we think the investment is worth the work. The work is worth the investment. And the healthcare system, I would argue, is one of our biggest problems in the state right now. Education, of course, housing, of course, demographics, of course, and healthcare is right there. I won't categorize them, but it's right there. And the healthcare costs are driving some of the economic limitations in our market. That's driving a lot of the school property tax. It might be the biggest driver of school property taxes, the school budget stream. So to really deal also with demographics, high commercial prices hurt our young. They have a difficult time supporting healthcare, and it hurts our businesses. So we would argue that it's very important to deal with that problem, and that does take investment. And some of these tools I think are very good. Lowering the hospital prices in a judicious and wise way would be beneficial. We are worried about losing Blue Cross Blue Shield, and if we lose Blue Cross Blue Shield, you will lose providers across the spectrum of healthcare. This will allow us to give us a tool to help protect that doesn't happen in the businesses. So we recognize it's a significant investment. The way this is structured here, I think is smart, because if we choose not to do these things, we don't need the positions, right? If we don't do ahead, or reference-based pricing doesn't go forward, I'm not going to ask for any positions, just the ones that we already discussed. And then the appropriations, similar. All of the work does take contractor resources and support to do the work. So if you look at the all-pair model, which might not be the best example to use when asking for resources.
Any example is fine. Get work done, you need help.
But the monitoring to make sure that there are risks whenever you change anything, there's institutional knowledge that goes away. Different things pop up and problems pop up. So part of the problem with, or not a problem, but one of the things you need to watch for in a global budget is standing of care. If you have a cap, do they stop seeing patients to stay under the cap? So you then have an access problem. So you have to watch for that. And that takes resources and data to do that. If you do it well, it can be very, very positive. If you don't do it well, you have a problem. The other thing that can happen with a global budget, if they're capped on certain things, they can go and invest in other things and grow those that are not subject to the cap. So a hospital inpatient care, outpatient care might be covered by the cap, but is there pharmacy? They make a ton of money on pharmacy. Do they just stop investing in the care in the hospital and focus the investment strategically on pharmacy? Similarly, this was a condition relating to the network, is they have hospitals in New York. If you have a cap here, is it strategically wise for them to put their doctors and their intellect and resources in growing New York where there's no cap? So we had a condition in our budget order to address that. You have to monitor for it. You have to watch it. So that takes time and resources to get the data and do that. The other piece is just, even with the all-payer model, just reporting requirements to the feds for all the monitor, that takes resources too. So I think the contract for the all-payer model, for just the data, the team outside of the state that did the work, the contractor, very significant costs. That's at deep six figures annually to do the work, to do the monitoring. So these things can be really good, but you got to do them well, and that does take investment. We're still crunching the numbers to make sure it's exactly right, and we'll get more information on that. But this is significant money. We recognize that, and we'll get back to the debate.
Good. Yeah, no, thank you for that. The numbers are sort of placeholders.
Yeah. The only other point I'd make, which I testified to yesterday in Senate Appropriations, so the chair heard, if you look at the Care Board's operations and compare it to other regulatory bodies in other states or even within the state, we are lean, and we need to be lean because the state has no money at this time. But to give you a sense, I think we have it's around 30 people that work at the Care Board, 32-ish, 36, something like that. The PUC and PSD, which regulate the energy industry, is 80 people. So significantly bigger to regulate energy versus healthcare. And I'm not saying that their positions aren't needed, they are, but we're just significantly smaller. And then Maryland and Massachusetts that also do healthcare regulation less broad than we do, more narrower than we do, have multiples of the number of positions that we do. So we need to get everything we can out of the positions, but if we're doing more, it does take more investment.
Thank you. I do have a question, and I know that we've got time, and I know we have the NEA here. Did you want to say something after Chair Foster's completely? That would be good. So one of the things we heard this morning from Jessica Marcella, who's has great expertise in payment reform and payment generally, was talking about how reference-based pricing is simply a continuation and would continue the sort of the overutilization and continue some of the problems that we see with fee for service. And I guess I would add in unless. And how do we get to capitation? Global budgeting, how do we get to payment reform that includes value-based information and shifts to, as we've heard many times, right care, right place, right time. But so you're thinking on reference-based pricing, because it is right now, as Senator Cummings continues to say, it's the hot ticket. Everybody's talking about reference-based pricing. Question I have, it will save money. It's a common question. It will save money in a more or less a short term. Is the work investment in reference-based pricing upfront worth it if our goal is to get to a different total cost of care coordinated, capitated model?
Yeah.
Help me.
Yeah, no,
Help us.
good question. So when you say capitated model, value-based model, there's different ways you can interpret what that means.
Exactly.
You can argue a reference-based pricing model with a cap is a capitated model. What Maryland does on the commercial side is they set the budget, how much money a hospital can have, and then they adjust the commercial rates to land at that cap.
That was my thinking. Good.
So
Yeah, good.
reference-based pricing, rate adjustment, rate setting is that. It is a cap. The other thing I would consider is, what is your problem in your state that you're trying to fix? Maryland is a very different state than Vermont. We historically have not had a utilization problem. We have the opposite. We have an access problem. So is a global budget where you don't get paid for every patient through the door the right thing to improve access? So this is a analogy. It's not perfect. I'm a lawyer by practice. I've worked at big firms and the Department of Justice. And when lawyers get paid by the hour, they bill more hours. Pay more, they may not. Actually, lawyers usually work more and get paid more. So that might not be perfect. But if you have an access problem, if you get paid less and you need to hit the revenue, you might see more patients. And you see that at some of the independent practices. When they don't get the rate increase, ask them what they do. They open up slots. And when we've reduced some of the budgets recently, we've seen some of the hospitals react to that less rate by opening up slots. So if we're trying to increase access, a fee-for-service type model might actually be beneficial. Now, if you have gross overutilization and you're really trying to tamp that down, a global budget can be really good. I actually think there's a combo that's appropriate. And here, we need to reduce the commercial prices, period. Now, do we also move to a global budget? I think ultimately global budgets would have a lot of benefit. It's a timing thing, a sequencing thing, and investment.
Good. I mean, so you're reinforcing the thinking that that's been going on here.
Yeah, the other thing I'd worry about in a capitated value-based payment is there's different ways to measure how much money they would get or the outcome. The truth is, I would worry about the financial impacts of hospitals from doing that too. Yeah, we're seeing worsening population health, and we're doing a population health value-based payment, and the population's getting sicker, the hospital gets less money. That will hurt some hospitals that don't have the ability to really impact that. Similarly, we're seeing risks or some noise around quality. You have a quality-based metric on how you get paid. You might not have enough money if the quality's going down. So there are things, it's not just so simple of, it's all of these things have a lot of nuance.
We got it. And the important thing is that we sort of get it, but that you guys really get it.
Or staff does.
Sometimes we should just get out of the way.
No, well, that's what I'm saying. We have, but it is not unhelpful for us to understand the language and the concepts. It is not unhelpful. So that when we put something in statute, we know that the experts are going to be able to use it.
It also holds us accountable, which is really important.
Exactly.
So we appreciate the efforts.
Thank you. Perfect.
We'll try to get you the language
Yeah,
in the next
especially Jen.
day or
Yeah,
so.
we'll try and work through.
Probably day.
We're going to be working through a lot of ideas that folks have brought us, but this is really helpful. And I know we have 15 minutes and I'm going to add,
And I need to.
then you need to go.
Yes.
And we're gonna replace, we can't replace you. There's no way to replace you.
Yeah.
But we'll put someone else.
Don't be afraid to.
And Colin, you're here from NEA, and I know that you had something you wanted to share with the committee. And I'm not sure who I shared it with yet, because I haven't had time. So it might be a surprise, and I'm looking at Jen and Nolan as well as Dan and Larry and everybody else. Sure. Thank you for being here.
Yeah, good to be here. Thanks, Senator. For the record, Colin Robinson, Vermont NEA. Good to see familiar faces, see some newer faces as well. And I wanted the language that Senator Lyons was referring to, hopefully won't come as a surprise to some of you. Senator Lyons, Senator Kitchell last year, and other of your colleagues worked to get study language in the budget last year that allowed the Green Mountain Care Board to look at what reference-based pricing would do for the state employees' healthcare pool and for the public education healthcare pool, which comprised about 60,000 lives in Vermont. And that their report came out in December and showed that impact. And I would say for us at Vermont and our 12,000 public school employees and the 35,000 members in the VHI pool, it showed not only what Chair Foster spoke to, the fact that healthcare costs are a major, if not one of the most significant or the most significant driver of property tax increases. But by moving to a reference-based pricing model, you can realize significant savings for property taxpayers as well. And so the language that we've had conversations with the care board over several weeks and time over this, building upon their report. And recently it's been talking with Chair Lyons about seeing this as an opportunity to pilot and start with the healthcare pools for state employees and public school employees as the first step on the work that you are beginning here in this bill toward reference-based pricing for the full commercial market. We have the data, we have the analysis, and the language would actually charge our pools with doing this. You, the legislature, would direct the pool for state employees and the pool for public school employees to implement reference-based pricing for our pools to contract with Medicare Pricer to do that analysis and implement that as soon as practically possible. And therefore realize those savings for property taxpayers, which is obviously a really critical conversation as it relates to education and another really big system that you and your colleagues are tackling. So that's sort of the kernel of the notion. It is highly complementary to the work you're doing. It's a first phase of what is going to be obviously an incredibly comprehensive effort that you're beginning at the board's beginning.
First, I want to thank you for bringing it to our attention. And I know I met with NEA and BSEA yesterday and I'm surrounded, but and I know that you've talked with the Green Mountain Care Board. There's some nuance to this. Absolutely. Because we don't want what you're doing to determine what the board ultimately will do.
Sure.
So there's a framework, there are guardrails, as I started thinking about this, we have to ensure that if this goes forward, the committee likes it, sounds like something we could do, that it doesn't tip everything over.
Absolutely.
You get it.
And
So just so you know that.
to be clear, we recognize, and I don't want to speak for VSEA, Vermont NEA. Those of you that were on the committee remember last year, we were in here talking about prescription drugs because the major cost drivers for healthcare for not only public school employees, but all Vermonters are pharmaceuticals and hospital costs. And so this is phase 2 of that conversation because healthcare is hurting all Vermonters. It's hurting our kids, our families, our students, our communities, but also our taxpayers and our members. And so absolutely, we see this as part of a continuum, part of the conversation, and part of the comprehensive effort, which is well positioned to move forward first.
Right, so there will be conditions in there, and it will not suggest that what you do will end up being the model that the board follows. In fact, it may, it'll be informative, but we don't want this to change the work that the board does. Let's say that, right? That's what I started thinking about after we had a chat. I think you get it. It's good. And I'm going to look to the board for their,
welcome their comments.
If they have them. I don't want to.
Yeah, I'm Owen Foster for the record from the care board. We hear the risk of being if NEA gets lower prices, does it spill over to the broader commercial market in Vermont that has some difficulty paying? And the answer is we look at affordability and healthcare costs at a large level. That's part of our job. We're always looking at the overall cost. So if the NEA prices go down, I don't imagine the care board will say, hey, let's increase it for everybody else. That's not what we're going to be doing. We look at budgets at a large level, but we wouldn't be looking to cost shift onto other commercial payers.
Right.
Now, if a hospital has really great pricing and really phenomenal performance and really low commercial prices, we'd look at that budget and say they might get a higher rate increase than they otherwise would. We've done that in the past. If a hospital has really high prices and they lose, $500,000 from this change, it would be a different conversation and evaluation. But we don't see this as being problematic to our ability and our authorities to watch the overall healthcare
Okay.
costs.
So, and just as we're going to get some language, which will be helpful, and Jen will have that, and then we'll run it by the board as well as this group around the table. Because thank you for bringing it to us. There's a lot of interest in doing that. We saw that as one piece of a larger system reform that needs to happen if we're going to prevent crisis in the future. So, but we appreciate the time and effort
Yeah.
very
And,
much.
We do have some language to you in Kiki, and so happy to walk through that at a later point. I think it does need Jen's eyes.
Later,
Uh,
if make sure Jen.
Not too much later, to be clear. I'm not,
There's not a
There's not
lot
much
later
later.
in this room, but it'll happen going
Yeah.
forward. So appreciate that.
Yes.
Thank you.
yeah, thank you for your work.
All right.
I understand, Senator, you know, Barb Griffin?
Very well.
Yeah, so,
You see what you just did?
No.
So what we are going to do at this point, we're still.
Okay, I apologize.
we're not-
I apologize,
We haven't
Senator.
done that yet. Before you talk, Senator, if you're all set and you.
Wonderful, thank you.
But we are not yet finished. I just wanted to say to the committee, we've heard a lot of testimony, and tomorrow is not different. Tomorrow, I just want to make sure we are going to start in at 8:30.
Boy.
And we still have people who want to chat. The doula bill might get attenuated somehow. It's already half an hour. I don't know how we're going to do that. I'm not thinking we're going to be spending all the time on Friday on all the other bills that are there, but we'll see what we can do. I have been talking with Jen, with Chair Foster, and with Secretary Samuelson, trying to sort out what is doable. We've heard a lot of testimony. I think there's a lot that we're hearing a lot of agreement and some minor changes, and then some major suggestions. So when we get the bill before us, I'm hoping, and I'm looking at Jen, we may be able to have some decision points to make our decisions about how we want to go forward with the bill and what's included from various folks, whether it's Healthcare Advocate or whether it's Green Mountain Care Board or BOZ or whatever. So my ask is in every waking moment that you pay attention and look at the testimony. I keep spreading it out on the dining room table because my desk isn't big enough anymore. And how we can get this bill over the finish line. There's huge interest in having this bill go forward, huge interest. So we want it to happen. It's important.
So I don't see that we've got markup necessarily on here.
Well, Kiki will fix that.
Okay. Because it would be nice for all of us to sort of do a proof
That's
markup.
the point I'm making right now. We're gotta be ready for that markup. And it will be tomorrow morning at 8:30 is markup.
Okay,
And
we'll be here ready to go.
we will put Jenny Samuelson up front. And that will be a short time.
Right.